Right above the gastroesophageal junction lies a narrow span of tissue measuring roughly 2 to 3 centimeters. Clinically, this distal segment is one of the most structurally vulnerable zones in the human body. The primary weakness is built into the anatomy itself. The left posterolateral wall of this lower esophagus contains significantly fewer muscle fibers and neurovascular structures than the upper portions of the tract. Second, this exact segment is forced to narrow abruptly as it tasses down through an opening in the diaphragm. Every time a person swallows, coughs, lifts a heavy object, or bears down, physical pressure focuses directly on this junction. The combination of a naturally thin tissue wall and a rigid anatomical bottleneck forces this distal end to constantly absorb immense physical stress from both inside and out, creating the precise conditions for catastrophic failure. A sudden violent spike in intraesophageal pressure, usually triggered by heavy retching or forceful vomiting, can easily push that weak left posterolateral wall past its mechanical limit. When the tissue fails completely, the result is Boerhaave syndrome, a spontaneous, full-thickness transmural rupture of the esophagus. Physicians rely on a diagnostic framework known as Mackler's triad to identify this specific blowout amid highly variable presentations. The presentation begins with the first 2 symptoms, severe, sudden lower chest pain that often radiates straight to the back, followed closely by a history of forceful vomiting. The third defining symptom is subcutaneous emphysema. Because air physically escapes through the ruptured tract and tracks upward, a physician can feel a distinct crackling sensation when pressing on the skin of the patient's neck or chest. This chest X-ray shows exactly what clinicians look for to confirm the diagnosis: a clear pocket of mediastinal air, indicated by the arrows, that has leaked completely outside the esophagus. Any spilled gastric fluid or air rapidly infects the chest cavity, leading to fatal mediastinitis and sepsis. Survival depends entirely on an immediate surgical thoracotomy to open the chest, clean the infection, and stitch the tear. Distinguishing between severe gastrointestinal distress and a full-thickness structural collapse is an immediate matter of life or death. That same narrow choke point through the diaphragm also makes the distal esophagus highly susceptible to physical blockages and accidental surgical trauma. If a foreign object, like a button battery, gets lodged in this lower thoracic section, it triggers severe chemically induced tissue necrosis and perforation. This tissue also faces chronic chemical assault from below. Untreated gastroesophageal reflux disease constantly bathes the lower lining in stomach acid over years or decades. These diagrams illustrate adaptation to chronic exposure as the normal esophagus rewrites its cellular structure into Barrett's esophagus. In the endoscopic photographs below, the healthy, pale tissue in image A is entirely replaced by the reddened columnar lining in images C and D. Whether the source is a trapped foreign object or years of silent acid erosion, local mechanical and chemical constraints actively rewrite the cellular integrity of the lower esophagus. If that cellular change progresses to esophageal cancer, a tumor length reaching 3 centimeters becomes a critical clinical threshold, carrying a high probability of invading the surrounding adventitia. This region also facilitates a dangerous phenomenon known as skip metastasis. Malignant cells enter an uninterrupted longitudinal submucosal lymphatic plexus, utilizing it as an anatomical highway. Because this network lacks segmental barriers, a localized tumor at the gastroesophageal junction can send cancer cells straight up into the cervical nodes of the neck, making accurate surgical staging highly difficult. On the acute side, clinicians must also weigh superficial threats. A patient presenting with bright red bloody vomiting is often suffering from Mallory-Weiss syndrome. These comparative anatomical drawings highlight the specific mechanical difference. While Boerhaave syndrome on the right is a transmural rupture spilling gas and fluid, a Mallory-Weiss tear on the left is strictly partial, limited entirely to the internal mucosal and submucosal layers. Evaluating a patient means mapping the exact depth of tissue failure, from a superficial bleed to submucosal cancer tracking to a full-thickness blowout. The internal health of this entire 3-centimeter zone is heavily dependent on the surrounding anatomy, specifically the esophageal hiatus of the diaphragm. This elliptical opening is anchored by the elastic phrenoesophageal ligament. Together, they act as an external muscular sling that physically reinforces the lower esophageal sphincter. This localized compression mechanism is the primary barrier keeping stomach acid trapped in the abdomen. When these supporting ligamentous tissues stretch or weaken, the anti-reflux barrier fails, allowing a hiatus hernia to form as abdominal contents push upward into the chest cavity. In a sliding hiatus hernia, designated as type 1, the gastroesophageal junction itself shifts up into the thorax. This breaks the seal entirely, initiating the severe reflux that drives Barrett's esophagus. In contrast, during a paraesophageal hernia, the junction remains firmly below the diaphragm, but the upper portion of the stomach rolls upward, ballooning parallel to the esophagus. While the reflux barrier stays intact, the displaced stomach introduces immediate mechanical risks, including gastric volvulus, strangulation, and loss of blood supply, creating a sudden surgical emergency. Treating a microscopic cellular mutation, repairing a massive structural herniation, or surviving a sudden pressure blowout all trace back to the same anatomical choke point. The outcome depends entirely on understanding the precise mechanical limits of the distal esophagus. When a patient presents with an esophageal emergency, survival depends on measuring a single critical dimension: depth. Clinicians must immediately identify exactly how far a tear penetrates the structural wall of the tissue. The first presentation of trauma we look for is a Mallory-Weiss tear. This is a superficial longitudinal laceration that only breaches the innermost mucosal layer of the esophagus. These shallow tears are usually the mechanical result of severe retching. Because the damage is restricted to the surface, the management protocol is strictly conservative. The tissue typically heals spontaneously within 48 to 72 hours using acid suppression or a simple endoscopic clip to halt any persistent bleeding. Management changes when the structural failure extends entirely through the tissue. This is Boerhaave syndrome, a complete rupture. In clinical terms, the tear is transmural. This structural collapse allows swallowed fluids and gastric acid to bypass the digestive tract entirely and leak directly into the negative pressure space of the mediastinum. Containing that leak requires aggressive intervention. The protocol mandates strict nil per os, or NPO, status, immediate broad-spectrum antibiotics, and emergency surgical repair. Even with rapid intervention, the contamination from a transmural rupture carries a mortality rate between 20 and 40%. Physical trauma represents a highly acute, purely structural failure, but the esophagus is equally vulnerable to chronic diseases, conditions driven by a failure of its functional mechanics and internal pressure gradients. The esophagus functions as a highly regulated pressurized conduit. Moving ingested material from the pharynx to the stomach relies on a delicate harmony between the surrounding intrathoracic pressure and two distinct physiological sphincters. Because this conduit sits within the thorax, its resting internal environment fluctuates between -5 and +5 millimeters of mercury during a standard respiratory cycle. When a swallow is initiated, the upper esophageal sphincter temporarily opens, allowing the bolus of food to enter the pressurized space. Once inside, a primary peristaltic wave takes over. This muscular contraction drives the intraluminal pressure up to approximately 25 millimeters of mercury to push the bolus downward. The final checkpoint in the sequence is the lower esophageal sphincter, or LES, the barrier protecting the esophagus from the acidic environment of the stomach. The LES maintains a continuous resting tone of about 20 millimeters of mercury. This pressure is driven by tonic myogenic activity, meaning the muscle itself generates the tone independent of autonomic neural signals. This high-pressure zone relaxes for exactly 1 second during swallowing to let the bolus pass, before immediately clamping back down. The sphincter is reinforced by secondary anatomical structures, including the oblique angle of entry, local mucosal folds, and the diaphragm, which all help seal off the stomach. Maintaining this precise 20 millimeter pressure gradient at the LES is the prerequisite for an intact esophageal barrier. When the barrier between the stomach and esophagus becomes incompetent, it leads to gastroesophageal reflux disease, or GERD. The primary functional failure is a drop in baseline resistance. The basal resting pressure of the LES falls below the necessary 20 millimeter threshold. Looking at this anatomical diagram, the right panel illustrates this structural failure. The blue arrows point to the relaxed, open sphincter, allowing green gastric fluids to wash upward into the esophageal body. To confirm this mechanical breach, clinicians perform an acid reflux test, placing a pH electrode exactly 5 centimeters proximal to the LES. If the electrode detects a decrease in pH to less than 4, it provides direct proof of severe, ongoing gastroesophageal reflux. Over time, this mechanical failure exposes the esophageal mucosa to repeated chemical burns, destroying its structural integrity. Clinicians use the Los Angeles classification of reflux esophagitis to grade the severity of that chemical damage. The system tracks the progressive expansion of mucosal breaks, scaling from minor grade A lesions under 5 millimeters all the way to grade D, where tissue damage involves more than 75% of the esophageal circumference. This destructive cascade can be triggered by pharmacological and lifestyle factors that lower the LES tone, such as excessive alcohol consumption, smoking, vagal withdrawal, or the use of beta-adrenergic agents. What begins as a failure of pressure eventually manifests as a failure of physical structure, corroded by acid. At the extreme opposite end of this neuromechanical spectrum lies achalasia cardia. Achalasia is a rare chronic neurodegenerative disorder. It creates a rigid mechanical obstruction rather than a loose, incompetent barrier. This diagram highlights the anatomical contrast. Focusing on the right panel, you can see the weakened smooth muscle and the distinct narrowing at the lower sphincter. This is a dual mechanical failure. The LES loses its ability to relax, and simultaneously, the esophageal body loses its normal rhythmic peristalsis. Because the transit mechanism is broken, swallowed food cools above the blockage. This stretches and dilates the esophagus, creating a sharp, tapered narrowing at the stomach entrance known as a bird's beak appearance. This backlog produces immediate clinical symptoms, most notably progressive dysphagia, difficulty swallowing both solid foods and liquids, coupled with the effortless regurgitation of undigested material. As the pooled fluids spill over, they trigger secondary symptoms, including nocturnal coughing spells and unintended weight loss due to the mechanical difficulty of moving food into the stomach. To confirm the incomplete relaxation of the sphincter, gastroenterologists rely on high-resolution manometry as the definitive gold standard diagnostic test. Using the Chicago classification system, this manometry data allows medical professionals to categorize the disease into one of 3 distinct clinical types to predict treatment response. While GERD destroys the esophageal barrier through functional weakness, achalasia destroys the conduit's ability to operate through neurodegenerative rigidity. Because the underlying nerve damage driving achalasia is irreversible, management cannot rely on medication alone. To restore transit, physicians must mechanically weaken or physically break the tight LES muscle fibers so that food can pass via gravity. The first physical intervention is pneumatic dilation. In this procedure, a specialized high-pressure balloon is inflated inside the sphincter. The force physically stretches and tears the constricted muscle fibers apart. For a more targeted approach, physicians utilize an advanced endoscopic surgery called perioral endoscopic myotomy, or POEM. During a POEM procedure, a camera is passed through the mouth, allowing the surgeon to precisely cut the inner muscle fibers of the LES from the inside out. The primary external surgical alternative is the Heller myotomy. This laparoscopic approach cuts the external muscle fibers. Because this destroys the barrier, it is often paired with a partial fundoplication wrap to prevent the patient from subsequently developing reflux. For patients whose surgical risk is too high, endoscopic Botox injections can temporarily paralyze and relax the muscle, providing a short-term mechanical reprieve. From deploying clips to seal a mucosal tear, to manually tearing a rigid sphincter, managing esophageal disease is an exercise in applied biomechanics.
If you found this video informative, please like and share, comment what you would like to see next, and subscribe to the channel to get notified about future informative videos.